In the next chapter, we will discuss the current guidelines for the aortic valve replacement. But remember, these guidelines may change in the next years with new procedures on the horizon, such as the transcatheter percutaneous aortic valve implantation. Already in 1968, Professor Ross and Professor Braunwald described the natural history of aortic stenosis. And we can clearly see that there is a long asymptomatic stage over many years, but once there is the onset of symptoms, the average survival goes down rapidly and patients have a very poor prognosis and are in need of urgent valve replacement. You can also see in the lower image, once patients undergo aortic valve replacement, the survival is almost restored to a normal life expectancy. What are the classical symptoms of aortic stenosis that we expect? Angina, syncope or dizziness, and of course heart failure with dyspnea and breathlessness, which are due to the increasing obstruction and myocardial overload. What are the current major indications for surgery and valve replacement? Symptomatic patients with severe aortic stenosis with a valve area below 1 square centimeter should undergo rapid valve replacement. The major symptoms encountered in aortic stenosis are dyspnea, syncope, and angina. The second major indication is once the patients develop reduced left ventricular function, even if they are still asymptomatic. And that's also the reason that these patients should undergo regular echocardiographic follow-up. Another indication can be even in asymptomatic patients once they have abnormal exercise tests with drop in blood pressure when undergoing exercise or developing severe symptoms at maximum exercise. And another important indication for surgery can be even in moderate aortic stenosis if other cardiac surgery is performed, such as, for example, coronary bypass surgery or other valve surgery is performed. Let's look at predictors of rapid progression in aortic stenosis. Of course, in the individual patient, the clinical course can be nonlinear and variable. An important role plays the valve morphology, or if the valve is bicuspid or tricuspid, but especially if the valve is very thickened and heavily calcified, this predicts the upcoming need for valve replacement and symptom onset. The severity of aortic stenosis is a strong prognostic factor. When you have a patient with a small aortic valve or a rapid increase of velocity or mean gradient over the year, then this patient needs to be watched very closely and followed up with echocardiographic controls. The degree of calcification is a strong predictor, and also the subclinical myocardial dysfunction, and now new techniques are coming up such as speckle tracking, strain rate imaging, and also biomarkers such as BNP can predict left ventricular dysfunction. How should we manage patients with aortic stenosis? As long as patients are asymptomatic, a follow-up every 1 to 2 years is sufficient, and we should perform a clinical assessment. We should ask them for symptoms and perform echocardiography to assess also the left ventricular function. But we need shorter intervals if the aortic stenosis is severe, if the valve is heavily calcified, if we have an uncertain left ventricular function, or if uncertain or unclear symptoms appear. So in summary, it's always important to look for symptoms in aortic stenosis or for signs of left ventricular dysfunction. If the patient has to undergo cardiac surgery for other reasons, such as cardiac bypass surgery, Then valve replacement should even be performed in moderate stenosis. But always bear in mind that the valve replacement is really an individual decision in every patient.